So we built a session for you, and we're gonna update you with the cruise of Apollo, which is still traveling, yes? Good. So I'm very happy to facilitate or co-moderate, you can call it whatever you want, this session together with Thomas Modine. My name is Ralph Stefan van Badeleben. And the faculty, the speakers are Nicolas van Meegem, Ole de Backer, Hendrik Triede, and of course, the one and only Alison Duncan, our queen. So without any delay, I'm going to ask Hendrik to start trying to convince us and convince you more importantly of the benefits of MR elimination, the potential of TMVR in comparison with TEER, for example. Hendrik?
Yeah, exactly, Thomas. This is the topic I have today. It's about the benefits of MR elimination. And these are my conflicts of interest. So why do we do MR treatment? Because we want to eliminate MR. We know that MR has really a negative impact on survival outcomes. And there are various treatment options. It goes from surgical repair, surgical replacement, or the transcatheter options we have. And then even if nothing of this is possible, guideline-directed medical therapy only. But it's all about reducing MR. And there are some lessons we learned with the transcatheter treatment. This is, of course, our focus today because we're faced with very old and high-risk patients usually. We know that the recurrence of MR and the residual grade of MR has a very negative impact on survival. This is now real-world data, looking at primary MR and secondary MR from the STS registry and the Giotto registry in Europe, showing that patients who are left with residual or recurrent MR grade 3 or 4 have a very poor survival. Mortality rates are as high as 44%. But this is not such a surprise, but we should know that also leaving moderate MR has a negative impact on survival. If you have grade 2 MR, your mortality rates are higher than if you have mild or non-MR. It also has, of course, an impact on further treatment. If you have recurrent residual MR after TEER, there's about 20% likelihood that you get a second procedure done to reduce this MR. It's about 20% in the total cohort, not much different between primary and secondary. And this is data from the Heart Failure Network Rhino Registry reporting that it doesn't only have an impact on mortality, but also on heart failure rehospitalization. So recurrent MR leads patients to coming back to the hospital for heart failure treatment more often than if you have no MR. And of course, more repeat intervention, as we just said. If we now look at the real-world data or the study data of the elimination of MR, it is, I have to say, very good in some studies. And Stefan van Baarlem is sitting here. He's one of the main investigators in the field, showing that in his hands and in the hands of some trial specialists, you can achieve perfect results, like in the global expansion E4 study, reduction of MR towards mild or less in 91% of patients. But this is not always the case, actually. You can also have studies showing only 60% of mild or less. And I think we are beyond the days where we could call moderate MR a real success after TEER. So it is variable, and you have to also have in mind that not every implant and not every echocardiographer can give you such a good result. If you look into real-world data, it's a little bit worse than this. And this is in contrast to the data we have from transcatheter mitral valve replacement. If you look not only at the Intrepid valve that we are talking about today, but if you're looking into all the transcatheter mitral valve replacement therapies we had, all the various devices, the one thing they have in common is that they can really reduce MR down to 0. So 100% mild or less MR after 30 days with transcatheter mitral valve replacement. And this is why we have potentially discussed this as an alternative for those patients where you at least can say beforehand that are not good suitable candidates for TEER. This is despite the fact that we know that TEER is a very safe procedure. So it is good that you don't die from TEER, but it's also good to know that there's more than just, perioperative mortality to look at. We have to look at the long-term results, and this is why we need transcatheter mitral replacement. And there are some patients, or many patients even, who do not have a good TEER suitable anatomy. And this has various reasons. It can be severe MAC, even associated with mitral stenosis. It can be calcified leaflets, can be multiple regurgitation jets. These valves are extremely complex. They have clefts. They have eventually short posterior leaflets that are not good graspable. And if you put all this together, there are some patients, and we know this, that are not good candidates for TEER. And this is why we need alternative treatments. And we also know that the suitability of TEER has an impact on outcome. If you are a good candidate for TEER, suitable anatomy, then the outcome is much better than if you're a non-suitable candidate. If you still do TEER, you will double your mortality, you will increase your technical failure rate by ×5, and you will reduce your procedural MR reduction by 20%. This is what you should know when you go into TEER procedure in a non-suitable candidate. And this is why we have the TMVR trials. And one trial we're going to discuss extensively today is the Apollo trial. The Apollo trial looks in a single-arm trial into those patients who have non-suitable anatomy for TEER. And there we examine the Intrepid valve as an alternative, and I leave this up to the upcoming speakers to go more into detail here. But it's very likely that in the future, once we have the data here and the data looks good, that we look into different studies, that we look into randomized trials comparing transcatheter mitral replacement with TEER in the future, even for patients who are not unsuitable, but who may have more or less difficult anatomies. And there are two patient examples I just want to show you. This is a 70-year-old male patient. He showed up with severe MR, highly symptomatic, a type 3B lesion, multiple jets, MAC associated, mitral stenosis associated. So for sure not a good TEER candidate. So we implanted the valve. Perfect results, you can see in the lower images here. Complete reduction of MR, very nice seating, no LVOT obstruction. So even in such a difficult patient, such a difficult anatomy, can with TMVR achieve a very good result. This is the second patient. This guy is a 66-year-old male, again with severe MR, showing up with annular calcification, short posterior leaflet length below 10 millimeters. So definitely not, again, a good candidate for TEER. And then after the implantation of the Intrepid valve, peak gradient is 1. There's no LVOT gradient at all, no parallel leak, and very mild transvalvular regurgitation. So excellent result, again, in such a difficult anatomy. And we can look further back. We now have, since the days of the pilot study, 5-year data follow-up on patients, and you can see that the valve is really long-lasting. This is a patient that was implanted 5 years ago, showing still excellent valve function. And if you go on a larger scale and look at the first 250 patients closely being implanted with the Intrepid valve, the reduction of MR is substantial and stays over time. After 2 years, all patients still have no residual MR. So in summary, we all know, of course, that MR severity is associated with poor prognosis. We also know that after TEER, there's a certain percentage of patients who are left with residual or recurrent MR, and this is, again, associated with worse survival and worse outcome. We know that TEER is safe, for sure, and we don't want to, replace TEER by TMVR. Definitely not, because there are such good TEER results. But for those patients who are deemed not being suitable for TEER, we need something different, and this may well be TMVR, because it has the potential to address those specific patients who are unsuitable for TEER. And finally, we'll only find out what the truth is if we do randomized trials, and I'm happy to discuss this with you. I see this coming up in the future. First of all, we start now with single-arm studies, but this is going to be followed up by randomized studies. Thank you very much for your attention.
So just let me remind you, thank you, Hendrik. Use the app for any questions that may rise. Keep them at least for 2 more talks. And we want you to participate, please. Let's make it interactive, because, we've been waiting for this field for a long time, and then we're happy that there is a dynamic in the field again and again, which Ralph's going to share with us. Thomas, actually.
Thomas. Hello, Stefan.
So we need an update from you on TMVR trial with Intrepid, the status currently, and one of the very interesting and important implementation, which is the 29 French. Ralph, please.
Stefan, thank you. It's my great pleasure to update you now on the Intrepid TMVR trial status, and we moved ahead. Of course, it has been a several-year journey that we have been transitioning. These are my disclosures. So if we look back into the TMVR program by Medtronic, we see that we have a valve design which consists of 2 stents, a more rigid inner stent, which holds a 27 millimeter tri-leaflet bovine pericardial valve, so pretty much a standard size. And we have a very conformable outer stand that reminds you of several other technical devices that we implant in the heart, may be in the valves, may be outside of the valves. And this symmetrical design also eliminates the need for rotational alignment. So you can come transeptal, you bend down into the annular position and you implant this valve. Currently, there are two different sizes available. It's the 42 millimeter and the 48 millimeter valve, which is currently in trials and clinical evaluation. There's also a larger one in development. So one of the big things we've seen the early EFS trial data, and the valve started like many valve designs with a surgical approach, with a transapical approach. And the first step was to move from the transapical approach, which has been abandoned in TAVR, also in the mitral field, to the transfemoral transeptal approach, which has been shown to be extremely safe, extremely competitive. So this was first investigated under a US early feasibility study, and you can see it here. It used a transfemoral access, venous access with a dilator and a 35 French sheath, which is of course large, but we should remember that we, in structural heart disease, we move up even to 40 French devices in the venous access. Currently, there is a multi-directional steering to access a range of anatomy, so you can get off an aorta hugger. You can of course bend down from the medial fossa ovalis transition into the left atrium down to the mitral valve anatomy. And there's also a clear visualization under both fluoroscopy and echocardiography, which becomes very important for implants because we have to align to the natural anatomy, and you'll see some changes in the implant techniques also here. And what is also nice, it's a single stage and fast deployment. This means that a typical procedure will only last about 30 to 40 minutes, which is a fast deployment. So what we've seen in the early feasibility study was an assessment by a multidisciplinary heart team, including interventional cardiologists and heart surgeons. Patients were selected with symptomatic, moderate to severe, or severe MR, as in the recent trials. And then the Intrepid transcatheter mitral valve replacement system was used with a transfemoral access and was followed up on 1 month, 3 months, 6 months, 1 year, and biannually up to 5 years. So we get long-term follow-up data. And the primary endpoints were implant delivery or device-related SAE, so mainly safety events through 30 days. And if we look at the results, even this early feasibility, which is early valve design, early generation, we can see one of the beauties of a venous low-pressure access and a transeptal access. And this is an unmet low all-cause mortality. So we're not talking about cardiovascular mortality, we're talking about all-cause mortality. And if we look at the 12-month results, we see that 6.7% all-cause mortality extremely competitive and low in the field. And this matches actually the best data that we can get on tricuspid valve replacement too. So typically the 1 year mortality there also is in the range of 7%, and this is very good. You can also see that major vascular complications rely on operator experience and also the transition from early cut down to the venous system to now completely percutaneous procedures. So you can use ProStyle, you can use a figure of 8, etc., to close this, and you get less and less vascular complications as the operators get more and more proficient with large bore venous access devices and procedures. So for these reasons, the Apollo trial shifted from a transapical approach to a transfemoral strategy due to these positive early results in the transfemoral EFS study. And the inclusion of this transfemoral system into the Apollo trial also increased the number of patients that were included and enrolled in the study. And it has been further enhanced here in Europe with the addition of the Apollo EU trial to the original US and Canadian trial. And it's currently the only treatment delivery option that is available under this clinical trial. And you can see the development here in the 2021 to 2023 timeframe. So what happened next? It was a redesign of the valve itself. And you can see not only the color changed, but the device and the capsule and the implant technology changed. Even though it looks pretty similar, you see 2 knobs to advance, you see several knobs, and you may see these different strategies of outer sheaths that are steerable, inner sheaths that are steerable, deployment capsules, etc., also with other valves. This is unique, and you see also a change in the valve design. On the left-hand side, you see the 35 French system, which has a longer sealing zone and a more ventricular position of the valve itself. And on the right-hand side, you see the latest iteration, which is currently used in the trial. That's the 29 French access, which is down 6 French, which is 2 millimeters. And you can see that the valve moved slightly up into the atrium. And by doing this, you cleared the LVOT much nicer than the previous generations. So 29 French, as a summary, allowed us to enable a completely percutaneous access. It is designed to improve the delivery system steering ergonomics because also the whole system is softer and more relying on native anatomy. And bioprosthesis is now optimized to reduce the LVOT obstruction and exclusion, so the screen fail rate, which dropped also significantly with the different device iterations. Another important addition, and we saw it in the first talk with Hendrik Trede, is that MAC now, so mitral annular calcification, is now regularly included into the Apollo EU trial, as is in the Apollo trial in the US and in Canada. And in Europe, during this month, the first countries are approved, almost 50% of the countries are both ethics and regulatory approved to employ now, instead of the 35 French system, the 29 French system for the regular trial. So there is a primary cohort with the primary endpoints. This is primary and secondary MR. MAC is now included. It's no separate arm. And there's mitral regurgitation, elimination, or reduction at 30 days. And all-cause mortality at 1 year. So we're no longer looking into short-term results, but we're looking into all-cause mortality at 1 year, so giving a much larger time frame, which is also wanted, of course, by the regulatory bodies. And they're roll-in subjects which are geographically variant. The increase with these patient strategies has also enabled to increase the enrollments dramatically. And you can see a doubling with the transition from transapical to transfemoral, but you also see a doubling of the enrollments now in the beginning of the 29 French system. And we're between 50 and 100 enrollments in the 29 French system, with an early experience in 5 US centers, now enrolling into many, many more centers. And it will be the regular type of therapy procedure now in the second half of 2025. So with these updates, you can see that the trial integration has been performed in the US now, and also between May and August here in Europe. This design, which should help us to steer and to have a more streamlined procedure. It also helps to reduce bleeding complications. You can see these 2 trial cohorts in the primary cohort, the roll-in subjects, and you see the reason with a more flattened design, less sealing phase going into protruding into the left ventricle, opening thus up the LVOT. So this eliminates one of the key factors. It's not the only one, but one of the key factors for screen fails with this trials. You see, it's a long ongoing endeavor. The transapical system started 1 decade ago in 2014. The Apollo trial started in 2017, but we made huge progress, as you can see here, with the transition of the transfemoral EFS in 2020 and the first trial enrollments in 2022. And now in 24 and 25 with the transition to the second generation 29 French system. And in the future, there will be an upcoming randomized trial with the lower screen fail rates that are now being achieved. Thank you very much for your kind attention.
Thanks. So I think it's very important to translate this presentation of Stefan into what we feel in real life and point out how effective it is and how important it is for the adoption of this therapy moving from a 35 French to 29 French. We have been all waiting for long to move from transapical to transfemoral, and I can tell you the same step is felt in our hands when we moved from 35 to 29. So Thomas, show us the case that you did for Apollo EU, the first case outside US, please.
Stefan, it's very nice from you, and I'm happy that you were also there with the first case in Europe with the 29 French. It was actually done at my site in Bordeaux, I think, but we did it together, so I think we can also comment together. I'm now changing to the name of the Centre Hospitalier Universitaire de Bordeaux, Haute-l'Évêque, à Bordeaux, France, on Aquitaine. These are my conflicts, well, pretty much related to Medtronic, as I see here. Okay, so the baseline characteristics, but it's your patient, Stefan. So I think it's a 82-year-old male with severe MR, as you can nicely see in these images. It's a typical patient that has a slightly elevated body mass index. He has some frailty, some cut score points. It's a New York Heart Association class, perhaps class 2 to 3. Had no previous mitral valve surgery, no previous TAV or SAV, but a prior CRTD system and also a normal RV function. So from the right heart side, of course, an ideal patient with a focus on the left heart disease. But it's not a totally easy patient because he is in HFrEF, so he has an ejection fraction of 35. Trace TR, which again is beneficial. Here only mild MAC, it could have been more. No problematic PA pressure, as you see, but the creatinine clearance, like in a lot of these patients, is already reduced below 50. Atrial fibrillation at 66% comorbidity in those patients, no COPD, nope. Diabetes, and the posterior leaflet is short, retracted, as you especially see in the 3D. If I want to point you to these Bordeaux images on the lower right side, you can see that in the P2 segment, this valve is really tethered down. Of course, you could also treat this by TEER, but we learned that the best outcomes and best potential outcomes are, of course, if we eliminate this situation. So, as an alternative strategy, TMVR sizing and neo-LVOT assessment has been done. You see we're in the range of 40 millimeters in diameter intercommissurally, and we have an outflow tract situation of 240 millimeters square. So this is a quite beneficial situation. So a typical procedure, which always starts in a slightly posterior, mid-fossa to slightly posterior puncture. We don't have to gain extreme heights, so something like 4.5 centimeters is absolutely sufficient because we have a depth in the left atrium to get over with a 5-centimeter capsule, which we have to get down to the mitral valve. It is a system where we only steer with the wire the primary sheath, and then we go non-wire based. That's a very important thing because these systems are self-stabilizing. So like with a lot of new technologies, actually no wire is needed anymore, which also reduces potential complications like pericardial effusion dramatically. You see, like in a valve-in-valve situation in the mitral position, you balloon the interatrial puncture that we did here, and you can nicely also see the CRT system, which helps you anatomically also where to sit the valve, but we do it mainly in echo. Now you see we change gears. We go to a large bore device. This is the 29 French device that you see here, crossing transeptal and then bending down. So this is something we learned from the TEER procedures, how to do this. It needs systems that bend more than 90 degrees and that are able to get off any anterior leaflet hugging. So we have to be totally 90 degrees perpendicular to all sides of the hinge points of the mitral valve. That's the key thing. We don't have to consider catching any leaflets. This will be done by the device itself, but we have to be anatomically correct. So this is very important to recognize this in the future. And this is why a new technique is being used, and this is MPR. And you will see this more and more in the future. So we're not looking at the device position orientation. We're looking first at the mitral valve position, and then we align the device to be perfectly in the target zone. And this is a very dominant and important change in the perspective of how we do these procedures. So we also look at 3D, and you see we're adequately banded. We're central in the middle. You see that the capsule is pointing directly between the two papillary muscles in the upper left image, and it's potentially nicely symmetric there. We even improve this, as you see here, by aligning this more and first expanding in this system the atrial brim, that you see here. Then we bring the brim down to the hinge points of the leaflets. We don't care for the tips of the leaflets. That's also very important, but we care for the annulus. So a correct annular position is quite important. You see three-dimensionally nicely the valve and the brim working under the contraction of the heart. Then we deploy the valve with rapid pacing, like in a TAVR procedure. And this is needed because we treat a lot of anatomies, primary and secondary. In secondary, annular motion is reduced, typically to 2 to 4 millimeters. But in a primary disease, it can be up to 8 millimeters height difference. In order to land securely, we shortly rapid pace 20 seconds to 30 seconds, like in the TAVR procedure, and then the valve is instantaneously released, as you see on the right images, the right two images. There you see the capsule is hydraulically steered, and it pops out in a very short time frame, and then the valve functions immediately, as you see on the outer right image. So these are the images after. The whole catheter time, and Stefan, you were perfectly doing that well in Bordeaux, was 35 minutes. The mean gradient is 1. There is no paravalvular leak and the trace transvalvular leak, no closure of the ASD. You simply go out like in a TEER procedure, but you eliminate, like Hendrik wanted this, MR totally to 0. And I think that's very important. And there, Thomas Modin was nice to also have me on the picture. You see Firas Saar from the Oregon Health System, who was also there, and this was the first European 29 implant. Thank you very much for your kind attention.
Admirable job. So we have a couple of minutes for discussions and questions. If you don't have any from the audience,
yes, Milad. 180 to 200 is not needed, so it will be, depends on the ejection fraction actually, and we test it prior to the real implant very shortly, and you just look at the motion, height motion of the annulus, nothing more. And we just want to reduce this, so it can be anything between 140, which is rare, typically 160 to 180. That's the target zone, and we try to keep it as short as needed, but also as long as needed, as short as possible and as long as needed. And it's in the range of 160 plus minus 20, I would say. And we simply look that the annular motion up and down by ventricular contraction is almost eliminated down to 1 millimeter. And then you have a more precise positioning. The reason is because the valve was moved out into the atrium, so the ceiling and landing zone became also 2 millimeters smaller, in order to have more LVOT clearance. This means we have to be slightly more precise in positioning this valve when implanting, but it doesn't change the timing. So it's as fast as before. You just are a little bit more precise in MPR, where to go and where to land the valve. That would be my points.
So Sundos, it's not about the valve itself. You've seen it, it's very stable, it doesn't move. It's just the movement of the heart. To be honest with you, I think this is not something that's gonna be mandatory when you get experience and you know better the device. One of the things we have been expecting in the beginning, and we still apply for all of us, is that when you compress this valve into very small sheath, you could expect sometimes some stress in the response of the leaflet, of the device itself. And we want to avoid this at this stage, but I'm sure that with the experience growing, we will not do this anymore. Yeah.
I would add even that, I mean, even if the brim is open atrial, pretty much, I mean, the patient is fully hemodynamically stable. There's no hemodynamic compromise. Yes? So these patients are, through the case, really very stable hemodynamically. We pace them shortly. We even do ventilation stop there for a couple of seconds, and then we deploy the valve. It typically takes there like 20-25 seconds, I would say, that pacing run. And immediately after stopping, the pressure comes pretty quick, within half a minute, completely back. Yeah.
Georges, please.
You said that maybe it's not a competitor for TEER, but I think at some point of time it will be the competitor for TEER, because as you had previous experience with TAVI, we start to think about the index procedure and then about the lifespan of the patient and the other procedure later on during the lifetime. And I think here also it's an important element, because TEER, it's maybe if you choose TEER, it will be one procedure. We cannot for the majority of the patient, we cannot repeat this procedure later on. And we know that some percentage of these patients will experience a recurrence of mitral regurgitation. This may be more appealing to treat and to have a better option for the future in case we had another problem. I think at some point we have to have a head-to-head trial for this, because we have to decide between both procedures.
So on paper, I think you're right, but there is also the reality, and the reality of the situation is that the screen failure rate now is still approximately 2/3 of all the patients that are being screened. So it's very difficult to compare in a randomized controlled trial a strategy that has a screen failure rate of 95, screen success rate of 95% versus a screen success rate of 40%. But I think this is time. This is a matter of time, and as we will discuss in the next presentation, the screening process has matured and is also a very dynamic process. So we are definitely getting better and better in identifying the patients and also in identifying more patients who are suitable for this technology.
Yeah, and I would add that I mean, this TMVR development in general and Intrepid in particular have been more or less on pause for some reasons in the past. I mean, we've been all a bit slowed down by co-opt results, and many of us in the community, but also the industry itself, were convinced that TEER is going to be the sole therapy, which is honestly something as surgeons never believed in. I mean, we know that all patients cannot fit into repair strategy, like all of them should not benefit of a replacement therapy. But as a matter of fact, for us, it's not a competition. It's complementary tools, and the best should be chosen for the patient. I would add to this, I think, when we decide for repair or replacement, also we take many factors into consideration: the age, the risk, the longevity, the durability. I mean, for me, if I have this on the shelf tomorrow and I have a young patient in whom I want to keep the doors open, this is a valve in which you can do a valve in valve, or maybe another valve in valve in. But you may generate other problems. So we are still really, despite the fact that we started in 2017, we're still in the beginning of the journey. Don't forget this. I mean, this is really a recent field that has been, again, slowed down, but I'm sure that now we entered the phase where we need to accelerate. Stefan, there are questions from the audience now.
Oh, yeah.
So the first question is, should we switch the paradigm of screening? First check anatomical suitability for TMVR. This goes a little bit into the direction. And only unsuitable patients should be further evaluated for TEER. That's per Alison.
No, I don't think so. I don't think we're at that stage just yet. I think, that one of the benefits, obviously, of TEER is you can have a patient in the morning and do the procedure in the afternoon, and there is some nuance still to the screening that is a little bit more complicated than for edge to edge. But I do think, and I made a joke with Hendrik earlier on, I don't understand the premise of the question about which patients is it okay to leave mitral regurgitation in. That, to me, seems like an argument that's created by people who want to leave mitral regurgitation. So, to be able to perform elimination of mitral regurgitation is the advantage of this particular case, and moving it to a safer access is the way forward. And to your point, for sure, this device, although it's not in the trial, would be anatomically suitable for potential valve-in-valve procedure in the future.
Yeah, I mean, you can even look at it from the other way. In surgery, we know already what to look for if we can predict a good result after repair. So we would not even start a repair if we would know that it's not possible. Then we go directly for replacement. And there are many patients, as I just said in my presentation, that are just good candidates for replacement. So why not go this way first and then only look if something else is possible? Because I totally share the question that we just heard. With placing a clip is fantastic if the result is good, but you leave the clip and you never know what happens in the future. Even if your initial results, the first 2-3 years look good, but there may be further remodeling of the ventricle, and then you always have these clips totally ingrown, and then basically the only thing you can really safely do is surgery. And this we don't want actually in this patient population. I think we should have an open mind for replacement technologies.
I think so too, but we have to respect the numbers a little bit. So we're approaching 300,000 clips, and there have not been 30,000 surgeries after clip. This would have been the 10% that don't achieve an optimal result. I also have in my outpatient clinic 10-year-old clips that have never been presented to a surgeon or to redo. We have to be honest on this, and this is a one-decade journey, and we need this technology. This is no question asked. But I think if we start with the 10% first, this is 30,000 patients, and I don't know whether Medtronic is able to produce them in 2 years, but we will end there, that there are enough patients out there, and I think we start complementary. All the other ideas are good. They were raised 5 years ago. But the reality is that in these 5 years, 200,000 TEER procedures have been done and approximately 2,000 TMVR procedures. But this will change over time. I'm absolutely positive. This is why I'm here. So I'm pro this technology. But we have to first start with 10,000 and 20,000, have the evidence, have the longevity, etc. We're positive on the way, but TEER is here longer to stay because it's extremely safe. And those who are very, very anatomically eligible, I think TEER is primary therapy for the next 5 to 10 years. After that, we can discuss everything. So this goes into the next question, potential question. This is for Ole, actually. They're asking, what about the permanent pacemaker rates in these procedures in TMVR? We know that there's a question here, and we have Ted Feldman here who can answer it too. In EVOC tricuspid, they are quite high. So how is it with Intrepid mitral? How is the difference in pacemaker rates between tricuspid approaches with the Koch triangle, and how is it in mitral interventions? So what do you say, Ole?
Well, I know for the tricuspid replacement therapies, there's an issue. Yes, there are quite some valves who have a problem because you're very close to the AV node. For the mitral, look, I mean, I have limited experience with the TMVR so far. We didn't have pacemaker. I think from an anatomical point of view, you're also away from there. You don't interact necessarily with the interventricular septum, AV node membrane septum, as far as I think. So I don't know. I don't know the real data. There's probably data on this. If you have done 100 TMVRs, how many pacemakers? I would think it's very low.
The experience, it's 0% for pacing for TMVR.
And this is across some different vendors. So we can just say TMVR, no pacemaker, no added pacemaker rates, just by age and comorbidities, but not by the device.
Because there is no compression on the conduction system, right? There is an LVOT in between the anterior mitral leaflet and the
conduction tissues are not.
Can I say something? So, in terms of imaging, it's actually a no-brainer to put a device in compared to repairing a device. It's much more nuanced to perform a transcatheter mitral valve edge-to-edge repair than it is to put a valve in. I think one of the reasons for having this type of panel is, particularly if you've got someone with secondary mitral regurgitation or a low ejection fraction, you 100% need the teamwork, the collaboration, because it's anyone in this room could put a TMVR device in. The nuance comes with managing the potential afterload mismatch or the LVOT, and that is easily learned. It's hard learned because there can be clinical risk associated with it. But with good communication between the implant team, this is a potential clinical risks that can be managed. And will be managed. And while I do agree with Stefan about the number of edge-to-edge devices, that's a bit like saying in the 1950s that we've got black and white television and we're never going to have artificial intelligence. It doesn't work like that. And when we have more and more experience of TMVR, there will be a head-to-head comparison. It will come. It just needs the confidence to do these procedures in large numbers.
If I can add something, I'm totally with you, Stefan. I also love the TEER procedures, but I think we should change one thing, and this is really something I'd like to ask our TEER implanters. Go away from calling moderate MR a success result after TEER. This we should really abandon. We should only talk about mild or less. This should be a good result. But moderate is not a good result in my eyes.
But you cited the expanded and also the class trial results, and this was not done there. So it's both values are given. This was the definition that was mostly defined like in Reshape in the year 2015. So we're back some time from there. And actually, if you read the conclusions, etc., this is given separately. So we have to say that the MR1 plus rate, and again, Ted is here, in the Everest trial was 43%. We moved up to 77. We moved now up to 80, 85,
But that's
90.
my point. That requires practice.
Yes, absolutely.
It requires a huge amount of experience.
Every procedure.
He's a good operator.
Yes,
good
exactly.
manager also.
Okay.
It's
And
far away
also,
from real data.
Also a good question.
This is a passionate debate. Let's go to the session.
We have the last question, which also shows the transition of the situation. So it is asked whether it's mandatory to prepare in the calf an Amplatzer ASD occluder, also perhaps other occluders, a closure system before you end the procedure. And there's also a transition, like we change from cut down for the access to the vein to percutaneous approach. Now ASDs typically are left open, especially with the 29 French system. On purpose, they're left open. It's like in a Pascal or in a other tier mitral procedure. Only if you have a rupture in the interatrial septum, or only if you have right to left shunt and you deoxygenate, which is less than 2%, then you will close the ASD. Otherwise, we now on purpose leave the device and the ASD open, also because it's dilated. And we know that within half a year, these septal ASDs that are dilated and just punctured, they will get smaller and smaller, and sometimes they even close. So you will not end up with an 8 millimeter, 10 millimeter ASD. You'll go down to 4 or 0 afterwards if you wait half a year. So typically no ASD closure, but of course you should have an ASD closure equipment in the room, not opened, and you can do it, and you have all the time to do it if you remove the system and then you check by echo. That's very important. So majority left open and closes itself.
Yeah, and quickly the question of Sophia Chen is, I think it's too early to compare Intrepid to any other device or any other device to Intrepid. So far, this is the valve with which we have the longest, the biggest, and most complementary results. Cephea is still in the early phases of development, and InnoValve also. So I think it's too early to pretend that any of these valves can compare with Intrepid. Hopefully we can do it in the future, but they are a bit behind in the race. I think we have to move on now, and Nicolas is going to enlighten us a bit more about anatomical obstacles and the screening for this Intrepid platform.
Yep, thank you very much, Thomas. So this was a very good discussion already, and what I'm going to present builds a little bit on the discussion and on the questions and comments that were coming from the audience. So I'm going to discuss the screening for the Intrepid TMVR and also how to navigate MEC, because we know that there is also a MEC component in the Apollo EU trial. And we are gathering information from already more than 600 cases, more than 250 transfemoral procedures, and also more than 75 cases in patients with MEC. And this has changed the way we are assessing these patients, the way we are doing pre-procedural planning. So there are two prospective trials. There is the Apollo trial in North America. There's the Apollo EU trial in Europe. There is quite some overlap. The major difference is that there is a separate MEC cohort in the United States, whereas it's incorporated in the Apollo EU trial. And basically, we are considering patients with a mitral regurgitation or moderate mitral regurgitation in combination with at least moderate mitral stenosis. And then we have our primary cohorts for the Apollo EU trial. So how does the screening go about? Well, first, we want to consider an anatomical eligibility. So we are reviewing the CT scan to make sure that from an anatomical point of view, it makes sense to proceed with a TMVR evaluation. If that is the case, then we will expand the screening process and we'll bring the patient to the screening committee. In the parallel, we're also already evaluating the tier and eligibility of the patients, because all patients need to be excluded from a tier procedure. There's also obviously a core lab involved, and then the patient gets a go or a no-go from the screening committee. What are the key inclusion criteria? So patients gotta have moderate to severe or severe mitral regurgitation or moderate MR in combination with mitral stenosis. The ejection fraction needs to be above 25%, and that also attests to one of the comments. Should we already compare TMVR with TEER in all patients? Be careful in patients with poor LVs. You have this concept of afterload mismatch that can haunt patients with poor LV function, so be careful with extrapolating all the data in all patients. And then we basically want to avoid futility, so we will exclude patients with advanced kidney issues, with very severe pulmonary hypertension, who are frail, also patients who require a TR treatment, and in patients with ballooning ventricles. So end-stage heart failure probably also is not the target for this prospective trial. What is TEER unsuitability? TEER unsuitability may be a little bit subjective. It may be different from one site to another. May also be different from one geography to another geography. But in principle, we will look at some of the anatomies that are associated with stenosis when you would consider edge-to-edge repair. And we're all familiar with, these valves that include some calcium, also more rheumatic phenotypes of valves, and then the typical clefts, the extreme valve complexities, short posterior leaflets, as the case that was done in Bordeaux, large coaptation gaps, not the ideal candidates for TEER, and also the inability to obtain proper grasping views by TEE. I think the last item is maybe a little bit controversial because you also need very good TEE views to execute a TMVR procedure, but I think you get the picture. When you consider TMVR, you always immediately bring the LVOT into the equation. And we're all familiar with the basic concept of a simulation of the neo-LVOT. What would happen with the left ventricular outflow tract when you implant or when you would implant a TMVR system? And we are familiar with an end-systolic analysis. And when that dimension, that simulated area, is below 1.8, that probably is an orange or maybe even a red flag. Well, we have matured in the screening process of the Intrepid device, and there is this cutoff now below 0.89 centimeters square. So everything above is under consideration for a TMVR. And this has to do with an optimized or a new LVOT scoring system that has introduced multiple parameters. So it's a multi-parametric system that has been developed internally by the Apollo team, and that takes into consideration multiple or different clinical variables or echo variables like septal thickness, posterior wall thickness, and LV dimensions, and then it generates a score that tells you what the risk will be for an LVOT obstruction. By doing this, by implementing this scoring system, we increase the screening success, and we are able to identify more patients who would be suitable for this kind of technology. What about MAC? We have this MAC cohort both in the Apollo and in the Apollo AU trial. What we consider is the distribution of MAC, the height of MAC. Is it protruding, and does it affect leaflet mobility, yes or no? So MAC is definitely not an inclusion, but it can exclude sometimes patients from TMVR, especially if you have these massive circular calcific MAC disease that would be either too small to allow the maximum expansion of the device or be too large for the device not to be able to reach to the borders of the mitral annulus. So in summary, I think that Intrepid TMVR trials are enrolling symptomatic patients with moderate to severe or severe MR or moderate MR in combination with mitral stenosis who are deemed unsuitable for surgery or TEER. The Apollo and the Apollo EU trials are aligned in the screening process, and enrollment of patients with MAC into the Intrepid trials is dependent on the MAC distribution and its potential interaction with the device as determined by a screening committee. Thank you.
Thank you, Nicola. We're going to continue with Ole de Backer, another case review which integrates a MAC distribution at the level of the annulus.
It's actually not a MAC case, to be honest.
Okay.
Let's have a look. on the case. Yes, here. But it's another example. It's a case performed 2 weeks ago, if I'm correct, with the Intrepid 29 French in Copenhagen.
You did it?
You should know it. Sorry?
Did you do the case?
Yes.
So it was 2 weeks ago.
I don't know if it's exactly 2 weeks ago. That I don't remember. Maybe it's 3 weeks ago. I'm not that good with my weeks, but anyway. So this patient, as you see, a younger patient, 72-year-old, farmer, robust guy, secondary severe mitral regurgitation. You see axiom fraction 44% also there. He has otherwise, which is very important, that you rule out, of course, pulmonary hypertension. The rule is, as Nicolas maybe also mentioned, the pulmonary pressure, the PASP, should be not higher than 2/3 of the systolic blood pressure. That was the case here. And then he had otherwise good renal function still. He had also a patient, just like in Bordeaux, a CRTP. So it's a patient which was on optimal medical heart failure treatment. He had already a CRTP, but despite that, you can see here, he has a really truly severe mitral regurgitation. This patient was actually first screened for TEER therapy. So I had him in the lab a couple of months earlier, where we thought it was still a suitable case, maybe or we could try, but you can see here, maybe it was also already a doubtful selection, but still we gave it an attempt. We went there for a clip placement, XTW, very central. And I can remember that I discussed with my imagers, well, there was still a massive jet and PISA on the medial side, on the lateral side as well, despite an optimal position of the clip. So we thought, well, if we leave this clip, there's no way back. Then we commit. So it's better not to place it and take it out and reassess it, maybe also for a TMVR therapy. That's what we did. You see his effective regurgitant orifice was 0.35, so we had a clear indication there. Then, of course, he undergoes a CT because that's mandatory to get the screening done for the TMVR therapy, for the Intrepid. First, the size has to be not too large because that's one of the reasons for screen failure. Maybe 25–30% of cases are screen failures because the mitral annulus is too large. This was not the case here. It was nicely suitable for a 48mm Intrepid. There were, however, some concerns initially for the LVOT. Because this was still, now the 29 is just arrived in Europe, but this patient was initially, if I remember well, a couple of months ago screened initially for the 35 French device. It's not only the change of delivery catheter, which is different, 35 versus 29 French, also the valve itself has is slightly different. Actually, the anchoring part in the current device is 2 to 3 millimeters shorter, so it protrudes 2 to 3 millimeters less into the LVOT, and that made actually that this patient initially just borderline did not pass the screening for the 35 French, but luckily it passed for the 29 French. In the meantime, we had actually also decided, in order to give the patient still a chance to go for an alcohol septal ablation, and as you see, my colleagues did this. But I'm afraid that maybe it only modified a little bit deeper down. You see here this bite taken out of that interventricular septum. So maybe it didn't give us a lot in the LVOT calculation, but still, because of the device, which is also optimized, and I know that the screen failure rate is lower thanks to the optimized and shorter stent frame in the current device. So this patient passed the screening. You see here transeptal puncture, exactly the same as in Bordeaux. You don't need very much height, so 4.4 centimeter height, septostomy done with a 12mm balloon, and then you go in with your sheet. Here you see that. Here we come out with our device, with the capsule. You need around 5 centimeters in before you can pull back on the sheet, because the sheet itself is pulled back to the right atrium. And then you have actually a guide and the inner catheter, which is left in the left atrium, to completely navigate without a wire indeed, and make your turns and get to your coaxiality. NPR is used. I will go further right away because we have actually some footage from this, some video recording. So here, this is what we call a kind of a towel twist maneuver. What is, you see here, my left hand is doing a posterior, a clockwise turn, posterior turn, that you see here. The guide is making a posterior maneuver, and my inner catheter is anterior. So you have to do that maneuver, they call it a towel twist maneuver, to get to a nice coaxiality, because that's the whole key. You invest there your time initially to get the perfect coaxiality. If you have the mitral annulus, it's normal. It's like docking a capsule to a spaceship. If you have not the right coaxiality, you will not get to a proper position of your valve and not have a good result. So the coaxiality, that's actually the key for success. So you spend there your time, your 20 minutes time to do that, and that's mostly based indeed on this MPR imaging. It's really mandatory, I think, the multiplane reconstruction imaging, to really assess how is your trajectory. Here, for example, our trajectory is still too anterior posterior wise, so then you can compensate. Also, I can share with you that the navigation of the system is really easy. I mean, if you're used to do mitral TEER, it's all the same terminologies and kind of almost knobs or maneuvers. So that's intuitively, as an operator, really nice. It doesn't feel like overly complex, which is really nice. Here you see also, you can also use other things than MPR as a kind of a double check. This is, for example, CT overlay, fusion overlay, where you can also, this is the mitral annulus here, as you can see, then you can assess as well whether your device is coaxial, yes or no, if there's parallax in the device. Then if you're good, then you open up the brim, as you saw also in Bordeaux, we open up the brim, and then it's about checking also your coaxiality. That's always the part. If you're happy with that, then you see that here. So also, how do you open that brim? It's not like in TAVI devices where you typically turn a knob. No, this is done here. You see my colleague, he's inflating an indiflator. So it's extremely controlled. Yes, you see me not touching here the device on this particular moment. My colleague just inflates an indiflator to a specific atmosphere. And then, in fact, this capsule kind of goes down and the brim opens up. So it's all extremely controlled. It feels as a very safe procedure and very well controlled. However, what we experienced then in this particular case, or experienced what we had, we were, despite doing all the effort to be perfectly coaxial, you see here that with the deployment, with the final deployment, that we thought now we're good, we're going to deploy the valve. We, as you see here, if you look here, this is the anterior, this is the aortic valve. We went down, we were committed to go down. See how much the valve expands. It almost expands to 80–90%. The valve is almost ready to be deployed, but then we found that we were going a little bit too deeper on the anterior side, maybe risking that we would end up really in the LV or the LVOT. So then you can easily, really easily, without any stress, abort and retrieve this entire. You see here the valve is almost 80, it's quite impressive, I think, 80–90% almost deployed. You can still abort and nicely, very well controlled, recapture this whole valve and take it out and go in again. So that's quite impressive. You can go very, very far in your deployment and still recapture. So it's not that as soon as you open the brim that you're committed and you have to release the valve. No, it's not. So no problem. Of course, we retrieve the valve. As soon as you have opened up and you went that far, you have to take it out. But that went everything went there very quickly and relatively easy. So then we came with the second valve. Here, from insertion from the second valve to deployment was 25 minutes. Yes, to give you indeed, that's kind of similar experience as in Bordeaux. So from insertion to deployment of a valve, it doesn't necessarily take very long. Here we optimize a bit and more our coaxiality. You see these very nice pictures on MPR, and I will show you here. So I will go immediately here. So expanding the brim again. I will go a bit quicker here. And let's see, I will go immediately to, before we then did the final deployment of the valve, we had some kind of a test dive. So that means the brim was open. Before you do the final expansion, you go a bit down to your proper depth, and if you're really happy, you go further with your indiflator and really release the valve. So we did a small test dive, a small test run of pacing, as you see here. And the patient came immediately back. We saw that everything was behaving properly and better as in the first deployment. We didn't came too low here on the anterior side. So then we were committed to go for the final deployment. You see that here. So here you see the pacing on. So how many seconds would it be? I think in total, like you can count, around 20 seconds. Here now my colleague. Now I'm going down. So I'm pushing the valve slightly. It's a couple of millimeters down to the proper height. 1 minute, Ollie. No, it's not 1 minute. Look, the valve will be soon released. It's like 35 seconds or something. I didn't time it now, but like 35, 40 seconds. You see now, boom, it's off. Yes. So now the valve is deployed and sits nicely. So it's less than a minute. And this
No
is the
pressure.
No, the pressure came within a minute. I mean, honestly, like the anesthesiologist also there was super relaxed. He hardly gave any inotropics, to be honest, just volume. Volume is more important than inotropics. Inotropics is even bad, I would say. You just increase the afterload as well. And here you see the result. I mean, there's absolutely no PVL. There was no LVOT gradient. I think it was 1 millimeter mercury, and a fantastic result. Also, this patient, 36 hours later, he was in a perfect shape. And he went home, yes, in an improved clinical state. You see here, so the mean gradient of the mitral valve, 2 millimeters mercury, LVOT mean gradient, 1 millimeter mercury. We also did not have to close the ASD, and there was a perfect valvular performance. So that was the case from Copenhagen.
So unfortunately, this session comes to its end. But I mean, what's striking here, and I can jump back on the question of Mrs. Chen, is that no loop to put on the submitral apparatus, no hooks to capture the leaflets with, position it, expand, look at the echo, and you're done. Quick, safe, and precise. And this is very important. This is what we want. Again, one of the inconvenience, I would say, of TEER is that you need half Stefan to achieve 90% of success or more. But here, anybody can do it, as Alison has been saying. So again, I think over time we will be able to show you more and provide you with more details about the results and outcomes. But I can tell you, in our experience, it's very encouraging, and I'm sure that TMVR place will grow over time. Thank you very much.